Alright guys, so I've drawn this diagram before recording so that we can simplify the fact of the inguinal canal. So what is inguinal canal? It's basically an intermuscular passage of what? We're gonna say that after a minute. And that is above the medial half of inguinal ligament. So the inguinal ligament, you guys, is the if you guys think about the abdominal wall, you had the external oblique muscle and it has aponeurosis. So that aponeurosis comes down all the way down and it makes condensation that attaches itself to the anterior superior iliac spine. All right, and the pubic symphysis, it should be here, pubic symphysis, sorry. All right, so pubic symphysis, consider this is the aponeurosis of external oblique. So it comes all the way and it makes layer and it condenses itself down to make the inguinal ligament and it reflects back there. All right, so this is what the inguinal ligament is basically. All right, so if you guys think about the inguinal canal, it's a muscular passage. We're gonna say why it happened, but let's just try to understand the walls first and then know why it happened. Now if you guys remember the layers of the abdominal wall, we had external abdominal oblique muscle, it has its aponeurosis, and then we had the internal abdominal oblique muscle, and then we had a transversus abdominis, right? Remember that these are the layers anterior to posterior. So I had external oblique outside, and then I had internal oblique following that, and then following this the transversus abdominis, and then we had the fascia transversalis. Okay, so these four guys, I please don't ever forget them. They were very important in the rectus sheath concept, remember, and they will be very important also in the inguinal canal concept. Now if I'm telling you that you have a canal and the anterior wall is made and those guys are making your canal, now you will tell me, okay, so the anterior wall is gonna be the outermost aponeurosis of all of the muscles, which is the external oblique aponeurosis. Great, so now you know that the anterior wall is made by external oblique aponeurosis. All right, and then you will tell me that the fascia transversalis is making the posterior wall because this is the most posterior structure. Wow, great job. So you know the anterior wall and the posterior wall, exactly like the rectus sheath concept. All right, now what about the transversus abdominis and internal oblique? Those guys are here. What's gonna happen is, guys, remember when I told you that the internal oblique comes out from the lateral 2/3, all right? And then I told you that transversus abdominis comes out of the lateral 1/3. If I'm telling you it comes out of the lateral 1/3, and I'm telling you the inguinal canal starts at the midpoint, so don't ever think that the transversus abdominis muscle is gonna make one of your walls. But who's going to make a support to one of the walls, which is made chiefly by the external oblique aponeurosis, is going to be the internal oblique because it's 2/3, all right? So part of it is going to come to support the lateral part of the anterior wall. So the anterior wall is predominantly made by external oblique aponeurosis and reinforced laterally by the internal oblique muscle. Wow, great job. All right, now what else? What else, guys? Internal oblique was basically coming from here. Let me use another color, orange. The internal oblique was coming out of the lateral 2/3, right? Because you know that the floor is the inguinal ligament, okay? It was coming from lateral 2/3, great. And it was supporting this part, also great. Now, if you look at the transverse abdominis, it comes out of the lateral 1/3. Okay, it doesn't contribute to my canal. Guys, at the superior surface, the arching fibers of transversus abdominis and the arching fibers of internal oblique are going to meet, and together they will make you your superior wall, and then they will go ahead posteriorly to make the reinforcement of the posterior wall. This is what I'm drawing now, is the reinforcement on the posterior wall. So basically the arching fibers of both muscles is going to make the superior wall, and then together they will join to do something called conjoint tendon, and it reflects itself back to support this part of the wall. So you will have the conjoint tendon coming and supporting the posterior wall, which was made by fascia transversalis. All right, so now we understand that the canal is made predominantly anterior wall by external oblique aponeurosis, posteriorly by fascia transversalis, and then reinforced anteriorly by internal oblique laterally, anteriorly and laterally, and reinforced posteriorly and medially, because here is the pubic symphysis and here is the iliac crest. All right, and this is the pubic symphysis and this is the medial. All right, now you guys, we have openings in the canal. We have opening in the posterior wall, which is oval or round. This is the deep inguinal ring, deep because this is the deep wall, right, the posterior. And we have a triangular kind of superficial inguinal ring, and it's medial in the anterior wall. Why do we have this? Because you guys, those openings were already, this is the reason why I had the canal. During development, guys, do I have the picture here? During development, guys, the gonads, you know that they will develop in the abdominal cavity, and then I think I already explained this in the reproductive module in very nice way, so we can just go briefly here. They were trying to migrate down, and there was a fibrous connective tissue called gubernaculum. It was trying to pull the gonads down to the final destination. The final destination in male was the scrotum, in female was the labia majora, so it was already connected here. So it will start to pull that organ all the way up until it reaches the final destination, and then we don't see it anymore. So during migration, this is what created the inguinal canal. The inguinal canal can be seen nicely in male because they have the spermatic cord. However, for female, because the ovary could not make its way outside because it got stuck with the uterus, and it formed two ligaments, one called the round ligament of uterus, and one, it shouldn't be here, it should be like this. So if we, let me just make it correctly. So when the ovary was trying to descend by gubernaculum, at some point it got at some point down here in the pelvic, let's say this is the ovary, at some point it got attached and it got stuck, so it had two parts, the proper ovarian ligament and the round ligament of uterus, and that is explained nicely in the reproductive module. So what you will find in the inguinal canal in female is the round ligament of uterus plus the ilioinguinal ligament. It's already there. However, in male you have the spermatic cord with all of its contents. It has around 9 contents, and it's mentioned in the reproductive system. And outside the spermatic cord you have also the ilioinguinal ligament. So don't ever never forget the ilioinguinal. Why do I have to remember the ilioinguinal and why it is there? You guys, ilioinguinal, from the name, it goes to the inguinal region. It supplies the conjoint tendon and the arching fibers. Remember in the renal module when we said that injury to this nerve can cause hernia? Because it supports the muscles. It supports the muscles that are doing the support to your canal. Your canal has opening during development, and these openings are potential spaces of hernia. So if there is increase in intra-abdominal pressure, the contents of your abdominal cavity, which is mainly the small intestine, can bulge into these openings. But thanks for the reinforcement that is going to stop this from bulging out and causing hernia. All right, and also this one is supporting my superficial one. Now, if I have a problem with the ilioinguinal, which is supplying the muscle that makes my conjoint tendon and my arching fibers, I'm going to have weakness in the muscle, and then the support is going to go away. So I'm going to end up having hernia. All right. Iliohypogastric also supplies those muscles, so also injury to that can cause hernia. Now let's go back to what we said here. So don't never ever forget your ilioinguinal nerve. that it passes through the canal to reach the inguinal region, and it supplies stuff here, and it also gives you a sensation in the medial thigh. So this is the inguinal canal, and here is the ilioinguinal nerve that goes and gives you also supply here. So if you have a problem with the ilioinguinal, the sensation also is going to be lost at this region. All right, now we talked about this, and we talked about how the fascia transversalis is making the posterior wall, and how those guys together formed the superior wall, and then arching fibers will do the conjoined tendon. So here we're adding up layers. So this is making part of my anterior wall. This is not making part. Here is the canal. Here is part of the canal. So this is posterior wall, and then adding up more layers. This is reinforcement, and then adding up more layers. The external oblique will cover the whole canal. You can only now see the superficial inguinal ring. All right. And I already talked to you guys about the idea that if we have, why do we call it direct hernia and why do we call it indirect? Because think about it. Let's just clear everything and remove these. Think about it. I have a deficiency here and there. If I have a coil of small intestine bulging out, it cannot come out of here. Definitely, it will come all the way from here. Okay, so any hernia. When the patient comes to you to the clinic, whether it's an indirect or it is direct because of weakness here, all right, it's gonna appear at the same place. So what will make you to know the difference? And once you open, you will find that the hernia was coming lateral to the inferior epigastric vessels. Now you are a surgeon, know that the structure is coming away. The structure is indirect. It's coming lateral to the inferior epigastric vessels. It means I need to do the reduction in the canal. So the whole thing is coming into here. So the whole small intestine passing through the canal. So I need to use different technique. I don't know about surgical techniques, all right? However, if this is a direct hernia, it's way simpler. It's just a direct one. Once you see it's coming medial to the inferior epigastric vessels, it means this is much only the bulging of the internal strangulated parts of your small intestine. All right, so this is the difference between the direct and indirect hernia. Okay, and this is a nice diagram to show you guys the spermatic cord. It has 9 contents or even more, 3 arteries, 3 structures, and 3 nerves. Okay, they are mentioned in the reproductive module, and you can see that the ilioinguinal is outside the cord, and this is a content in the canal. However, in female, you can see that there is a round ligament. It's kind of something like looks like a ligament in real cadaver. I didn't find a nice picture to show it here, but you'll just see that there is something like that. Looks like a ligament or something, and it goes all the way to the labia majus. However, the ilioinguinal, once you can see it, it's way thinner than the round ligament, and it ends up as very thin, small cutaneous branches, because it terminates as a cutaneous nerve to that region. Okay, guys, this is a nice diagram. I took it from Teach Me Anatomy. Okay, now let's talk about the innervation of the abdominal wall, arterial supply, and venous drainage.